Anyone who tells you there's no complications in their practice is lying to you, right? Realize that what people understand plastic surgery to be is so different to the reality. Really, the beauty of plastic surgery is it's about form and function. If you have a disfigurement from a trauma or a cancer, people treat you differently. Patients were told, you're obese, go away and lose weight. We started to say, actually, no, this is a disease. They can't help it. It's not laziness. It's not gluttony. All these things they've been fat shamed for years. It's genetic. I remember there was a patient I had who still haunts me today, a patient who had been torched, burnt by someone in the burns. I was a burns surgeon on call, and we had to make a decision to palliate a patient who was unsurvivable.
Now, can we talk about your cancer research with stem cells?
But if I was walking past in 10 years a patient with that disease that I elected, I'm watching those patients die for the rest of my career, there's a 100% chance that I would look myself in the mirror and really despise what I see.
Yeah. Let me ask you a question. I gave you $10 billion and 300 of the world's best scientists. Do you believe you could find a cure for cancer within 5 years? Rami, I've been asking you for ages, can you come on the Get Harder podcast? Obviously, we're very, very good mates.
Yep.
And most Sundays we catch up over a coffee.
Yep.
And you just tell me about what you're working on.
Yeah.
I thought, let's do a podcast about this.
Yeah.
So if you don't mind, can you introduce who you are and what you do?
Yep. Yeah, absolutely. Well, no, thank you for having me on. It's a great honor.
We made it happen finally.
We did. It's tough to find time during the week, but it's
especially for you.
It's worth it. It's worth it. Yeah. Look. So Ramin Shayan, I'm a plastic surgeon by trade, I guess. I kind of started in plastic surgery a little bit by accident, in that I wanted to do something in cancer, when my uncle died of a brain tumor when I was about 16. He was a young uncle, very close, and so I started in medicine from that premise. And I'd intended to be a sort of an oncological surgeon. I knew I wanted to do surgery because of the sort of instant gratification part of it, problem solving, that sort of stuff.
Yeah.
But through serendipity, I ended up finding my way to plastics. In fact, one of the professors of plastic surgery had a heart attack when I was on a ward round with him at 5:30 in the morning. And I sort of, just did the basic stuff, and he was okay, had his heart surgery, and then he sort of took ownership of me, I guess, in a way, and he started getting me by his bedside and telling me some of the folklore of plastic surgery. And I realised that what people understand plastic surgery to be is so different to the reality. And he was actually a guy who—
As an example?
Microsurgery, right? So breast reconstruction, head, neck and jaw reconstruction. If there's a defect in the head where the brain's exposed, plastic surgeons cover it. Limb salvage, all those things that are really fundamental to a lot of trauma and cancer stuff in particular. It's plastic surgeons who do it largely through microsurgery. So what people don't realise is Melbourne was the birthplace of microsurgery in the 70s through a couple of giants of plastic surgery, a guy called Ian Taylor and another guy called Bernie O'Brien. And they really, through their competition, it was St. Vincent's versus it was Protestants and Catholics, really, the tension. And these guys sort of went head to head, and by pushing each other harder and harder, actually became the place where the first ever successful transfer of tissue for like a limb salvage, so groin tissue, taking it off the body, joining up an artery and a vein to make it live immediately. That was the first one was done in Melbourne, not far from here at Panch Hospital. So he told me this folklore. I fell in love with it. I fell in love with his curiosity. He was in his late 60s and he was so curious. And that was infectious to me, and the capacity to do research. And so as a result, I started doing a PhD research project with him on growing and stopping lymphatic vessels, which are the way that the little vessels that cancer spreads through. But also if you have radiation or surgery for cancer, the blockage of them results in these big swollen limbs that is incapacitating. So this amazing untapped sort of area, no one was that interested in these patients. Yeah. They were sort of orphaned in a way.
Because they were too hard?
Too hard basket. Yeah, it was definitely in the too hard basket. Not very sexy.
No money in it.
There's no money in it. They're usually not able to work, so they can't pay you. Private sector, there was nothing happening. So it was a complete area of unmet need. And one of my other mentors, Keith Mutimer, said to me, plastic surgery is about the medical orphans. We own the medical orphans. If you want to make an impact, find an area that is untreated or there's unmet need and make that yours. So I did a PhD with Professor Taylor, went into the lab, and he said to me, look, you need to learn the language of molecular biology. So I went and found the best molecular biologists I could find, two guys who were at the time at the Royal Melbourne Department of Surgery, and went right back to the beginning. From being a resident in a hospital, a doctor, I went right back to being the guy who polished the floors and cleaned the shoes. Completely to the sort of lowest level, humble, and tried to learn everything. 3 years full-time doing that, and I came out with a different lens in the world. My curiosity was fired up even more. For stem cells, for cancer, for every type of reconstructive tissue engineering that we now do. And I went through my training, and I had this different lens, and I saw problems. People didn't want this difficult wound patient or this obese, neglected, unemployed patient. But to me, they were an opportunity to make that little difference, and almost like a real-life experiment where you could help that person with simple stuff that had been forgotten. So as I went through my training, another guy at St. Vincent's came and said, well, look, I've got this research organisation called the O'Brien Institute. Would you like to come and start a lab there? Here's some funding. It was irresistible, so I started a lab doing all those molecular biology things, which then translated across into my clinical interests. So that they sort of became one and the same, but different facets of the same adventure, if you like. And in the end, I became director of that institute. The irony was my old boss, Ian Taylor, the O'Brien Institute, was the one started by his adversary. So it was this bridging together of those two parts of that divide. And ever since, I just go around every day living an amazing adventure where I get to see clinical stuff, research stuff, try experiments that come up in the clinical world, try some information from the clinical world into the patients I see. And now I do sort of stem cells, adipose biology, fat biology, lymphatics, and cancer. And we've spun out a startup in the cancer space that we're doing very passionately. But all of it to me is one big adventure. It's just the curiosity that Ian Taylor gave me back in 2003. I've never lost it, and it's amazing.
Can we talk about the areas of plastic surgery you specialise in? Because I know because we talk about it. But I know you do lymphedema. What else do you specialise in? And can you take us through some samples?
Yeah. So there's through lymphedema, which is the swelling of the limbs after cancer.
Is it only after cancer?
Well, so there are two aspects to it. The ones I met the patients through was after cancer.
Okay.
I soon discovered after trauma as well. And then I discovered after that, obviously a lot of patients whose genetics had meant that the lymphatic vessels, it's the drainage system of the body basically. There's arteries, blood comes in, most goes through the veins, some stays behind to bathe the cells of your tissue. And that has its own ecosystem. If you block the lymphatics, which regulate that, you get an accumulation of fluid, and that then turns later into, it's like if you leave a lamb roast out, the fat coagulates, the lymph fluid, if it gathers in a body part, turns to hard fat, and suddenly you've got these limbs which weigh...
Stagnates.
Yeah. It might weigh 20, 30, 40 kilos.
Wow.
And they can't move, the shoulder dislocates, the hand's useless, the foot's useless, whatever the body part is. So the options to treat it using microsurgery are to connect those little lymphatic vessels, and we're talking 0.3 millimeters to 1 millimeter, that range, into a vein. So it basically bypasses the fluid blockage where the lymph glands have been taken out, for example, for cancer treatment, because of course the cancer spreads through those lymphatics into the body. So that's one aspect. The other aspect is lipedema, which is a fat accumulation disease. Now, I met these patients, again, completely neglected by medicine. And we came in, my wife's a researcher, and we met during my PhD, and we saw these patients and we said, how is it one patient looks identical? They've got a bunch of sisters who look nothing like them, and then another family, you've got someone who looks identical to this other patient. It must be genetics. And so, sure enough, we started a lab in it. We discovered a fat stem cell that's unique and different to normal obesity and to normal non-obese patients. Yeah. And so we started to give some legitimacy. These patients were told, you're obese, go away and lose weight. We started to say, actually, no, this is a disease. They can't help it. It's not laziness. It's not gluttony. All these things have been fat shamed for years.
It's genetic?
It's genetic. So now we're unraveling the genetics. We've published a few big papers from our lab on both the stem cell, the genetics of it, and we're finding that, and this is like literally hot off the press today, I've started now with some companies like MyDNA and so on to do gene testing. It was inaccessible before.
You know, Radic was just on. He owns MyDNA.
It's not a plug for Rad's company.
He plugged it already.
Did he? Yeah. So I'm plugging his company, but so I'm starting to get genetics of it. And I just had a patient I saw today before I came in who she's lost 100 kilos, but her skin, now that you try to take up the loose skin, is like chewing gum. Literally, like you put it somewhere, you take out a bit of skin, a few months later it just stretches like a melted candle.
Poor woman.
And I said to her, let's get the gene testing. Sure enough, today it came back with 7 hits in the collagen that absolutely explains what she's done, what's happening to her. And we were euphoric, her and I both, because suddenly there's a reason, there's a name to this thing, right? And so now I'm starting to more and more before I do, say, fat grafting, which is another area of interest, stem cell a treatment for radiation injury scarring. I'm now doing more comprehensive genetic analysis and all of the preparation needed, which again feeds into our research and research feeds into it, that we're able to detect and work out what gene defects will make them likely to have what outcome. Radiation is another big thing I do. So after cancer, you have radiation treatment to get rid of some cancer cells.
Yep.
And those cancer cells are looking at it's a critical thing. It's a necessary evil, really, but it does damage to the body. And the patients live with that damage lifelong. And it contracts the skin, wound breakdown, a breast implant, for example, if you've had radiation, it keeps contracting. And so I do fat grafting with stem cells to try and ameliorate and reduce that. And
is that reconstructive surgery?
It's reconstructive surgery, absolutely, after breast cancer, yeah. Sometimes we have to take the tummy fat, like you do a tummy tuck. This is a common operation I do. You take the tummy and you actually trace back the vessels that supply the skin through the muscle, through the abdominal wall, take the whole thing as a unit, put it on the chest and plumb the artery and vein from the tummy tuck fat into the artery and vein between the ribs, and it's living immediately as a pseudo breast. It doesn't have the lactation, but it's a breast that gives the patient the identity of having the breast replaced. So that's an example, right? And the radiation injury, it's always been thought as just nuking it. But in fact, in the lab, what we've just only last year published is that the radiation is actually turning off a molecular switch in the stem cells, in the lymphatic cells, that is causing them to be unable to replicate. So those cells, if they can't replicate, the vessels can't heal. You can cut it and it just sits there. It doesn't bridge across and heal. Now that's an amazing reality, because it means that if there's a molecular switch stopping it, there's potential to find the molecular switch that reignites it or turns it on, or an alternative molecular switch. And that's where it's really going. So that's where our lab's evolved to, I guess, and I'm sort of crossing the surgery and the research. It's because that's the way my practice is. It's they're completely inseparable. And so, the areas of surgery I've talked about, the microsurgery, the stem cell treatment, the lipedema, the lymphedema, they all fit into discrete areas of our research work. And on a daily basis, I've just seen 25 patients this morning before coming here. There's examples of all of those mixed in. And that's why I guess you get to cross-fertilize ideas between all of them.
I've actually seen photos of your cosmetic work as well.
Yes.
You're an artist.
Thank you.
What exactly, or what areas do you specialize in terms of cosmetic? Is it facial?
Yeah. So the wonderful thing about plastic surgery is it evolves, right? So your specialty evolves. From all that stuff I've mentioned, the patients came with post-weight loss. They needed those attended to. So I did some of the weight loss removal surgeries, such as arm lifts, thigh lifts, tummy tucks, then moving into breast lifts, breast reductions. And from that, the same patients come back and they say, look, I'd really like my face done, my nose done, my brows done. And so we offer all of those things because you might say, well, there's so many different surgeries. The principles are the same, okay? So it's about having an aesthetic outcome that restores what they had, or if there's a realistic and safe way to do it, enhances what they had. And so all of those things, I don't see them as separate parts. It's different anatomy. We're familiar with anatomy, the same concepts. It's restoring and tightening. And really the beauty of plastic surgery is it's about form and function. Form and function are inseparable because if you think about it, part of the function of the human body is the form of the human body, right? If you have a disfigurement from a trauma or a cancer, people treat you differently. your employment prospects, your prospects for finding a partner and reproducing or being able to get out in the street and have a good time.
Makes a huge difference.
Huge difference.
Yeah.
So they are inseparable. To separate form and function is very artificial, but a lot of the cosmetic, non-plastic surgery world, I guess, has cashed in on the boom in aesthetic surgery, and a lot of this is done via social media.
Yes.
And so it's not necessarily backed up with the experience in anatomy.
Which you're not on social media, of course.
I'm not on social media by choice in that, because I think that it can be misleading. It's very selective. And to be able to do a full consent process with a patient, they need to sit in front of you. Now, obviously, there's great aspects of education in social media, which you can do, and I probably should do more. But it's a matter of time and bandwidth, I guess, at the same time.
Why is it when you look at some Turak wives, with their faces all stripped back, they look like cats?
Yeah.
Like, why would a surgeon do that to someone and make them look like a catwoman?
Yeah. It's a really good question. I think there's definitely good evidence that different social demographics and different cultures have completely different ideas of beauty, right? So I think if you look at
this is in Turak. This is.
But that's the interesting thing, right? We're a series of villages here in Melbourne, and the aesthetics where you and I live are slightly different to, say, Turak, and there are different perceptions of what's overdone. Some people come and say, "I want to look done." They actually want that look of looking artificial, because it says to people, maybe it's a status symbol. I can afford plastic surgery. Maybe it's that they've been oversold the surgery so that you lose perspective. And this ties into body dysmorphia and body image a lot, because people tend to lose the sort of starting point of where they came from. And it's just a little bit more fountain of youth stuff, right? So I think there's a combination between the cultural differences, the social cachet, the symbolism of it. For example, my dad's from Iran. They do a lot of rhinoplasties. Why? Firstly, the head coverings mean that you can only really see the face. There's a disproportionate focus on the face. Secondly, ethnically, there's a lot of genetically in the Middle East, there's a lot of rounder, larger noses, which they want addressed. And so it's a status symbol to the extent that there are people who walk around with the bandages of a rhinoplasty who can't afford or haven't done a rhinoplasty, just to show that they could afford it as a status symbol, which is, when I went there, I was blown away by that concept. Because in Australia, you were trying to hide the fact then that you were having cosmetic surgery. Now it's more open.
Yeah.
People discuss it. Oh, I had this done, I had that done. And there's no right or wrong about that. But it's just that the fact there's a cultural emphasis changes with generations, with time. And now social media is seeing younger and younger facelifts. You're seeing people do more extreme surgery. You're seeing people do Botox and fillers as if it's a haircut.
It's crazy. But I also think some surgeons just do a really poor job.
Yeah.
Some surgeons just go over the top.
Yeah.
And then they may even come to you to fix it. I'm sure you've had patients come to you.
Yeah.
And they've seen a surgeon prior.
Yep.
And they hate the outcome and they go, look, Ramin, please fix me.
Yep.
Do you ever have that?
Absolutely. Look, I think one of the biggest things is expectations versus reality. And there's this sort of interplay between what the patient expects and wants, what they can safely have, i.e. if you push it too far, you lose some skin or some part of the body doesn't survive, or it just doesn't behave as you would like.
Is this with, say, a facelift?
This might be a facelift. It might be a breast reduction. But it's really plastic surgery, when you break it down, is what the patient wants. And then you come in and say, right, well, what's your appetite for scars? What's your underlying medical status that will tell us how you're going to scar and heal? And then what's your capacity for dedicating downtime to be able to look after yourself in the optimal way?
Yeah.
If you have a patient who comes in, I want, facelift and breast and this and that, and I'm flying to Tokyo and I'm going skiing and I'm going to go party, and well, it's clearly going to be a disaster.
Yeah.
Or I'm smoking, or even nowadays, the obesity thing is big, because we know obesity correlates with complication rate. And so now with these things like Ozempic and Mounjaro, you can actually reduce the weight medically much more safely than the old days when you needed bariatric surgery to staple a stomach, sleeve the stomach or whatever. So there's this ever-evolving piece about what's safe and what's possible. I think also where there's different conditions, it's about the patient understanding what the condition is. I've seen patients this week where they have gone from 130 kilos to 65, and they will tell you, I still see myself as I was. I can't. So that dysmorphia part plays in as well. all of these are swirling around. And when you see a patient, you meet them in a snapshot and you don't know which one it is. So it takes a lot of time to unpick that. And certainly when you get rushed in that process, when the patient is needing to go off overseas quickly, or you rushing them in, no one's ever happy.
Yeah.
The process of actually understanding and why, and also saying no, protecting the patient from themselves and minimizing what they do is a critical part of being a plastic surgeon.
Do you often say no to patients and say, look, hey, I just cannot help you?
All the time. All the time. I say to them, in the context of what you want, and in the context of your appetite for scars, your appetite for downtime, and all the other factors about you, it means that what you want, I can't deliver in your case, right? Now, you can modify those things if they're modifiable, and then you can deliver them. I had a patient yesterday who is very skinny, has had breast augments 20, 30 years ago, and wants the breast augments out and wants to fill them up with fat graft, right? So stem cells and fat put into the breast. The problem is she's skinny. She doesn't have a good donor side. So the discussion went, well, what is the cost you're willing to sustain? If I take them from your inner thighs and your thighs then become lumpy, the remedy is to cut out the skin and tighten it up. Are you willing to either have the lumpy legs, if it happens? Are you willing to have a scar if I need to cut it out? If you're not, and if it happens, right, then you won't be happy. So let's actually say it now that the donor side, because your legs you're very happy with and they're athletic looking, then why would you mess with your legs? It's risky.
Yeah.
So it becomes a case of if the risk is high and the benefits low, don't do it.
Yeah.
If the risks are low and the potential benefits high, that's an equation you can work out. But selling patients that there's no complications ever, that it's a perfect thing, there's no scars, it's magic, that's when patients become unhappy and disappointed. Okay.
Those wanting cosmetic surgery, what should they ask their potential surgeon when they go for a consultation? Like what are the things they should look out for to make sure they choose the right person for them?
I think there's that innate, do you gel with that person?
Yeah.
Are they willing to spend the time answering your questions, educating you? Will they be dismissive? Will they be rushed? Will they try and rush you into surgery? Those are warning signs. I think the fact is, and some of the laws that have come in Victoria at least are that, for example, for cosmetic surgery, you need to have a consultation, a second consultation before you can quote anything or book anything. You need to have a cooling off period after it has been booked. And you need to have a body dysmorphia screen, official screen that's done and cleared before you do it. And I think there was a lot of rancor about that because it's more admin and this, but I think it's a good thing because it's actually working out patients. And sometimes patients are surprised going, wow, I really do score high on this body dysmorphia. And I understand I have to have these. And the second consultation brings questions and that reveals that actually they weren't suitable. They don't have the requisite sort of personality type, the patience, the appetite for the scars, the downtime or whatever it is, or they're just not suitable for that surgery. But I think that process, if that's rushed or truncated, that's a warning sign. I think if you find that you're asking questions of the surgeon, they're evasive, they don't want to answer, they can't answer, or they're just saying it's all going to be hunky-dory.
Perfect. It's going to make you look like Kim Kardashian.
That's a problem. And I think that's where a lot of social media effectively is doing that.
Yeah.
Right?
It does. Social media is the worst for that. It drives that potential outcome, but it's not reality.
Yeah. Yeah. And so, for example, an abdominoplasty, right? If you have a tummy tuck.
Tummy tuck, sorry.
A 40-year-old woman, she's had 5 kids, has been heavier, gone lighter, and that person wants to be looking like an 18-year-old model they see on social media, that you have to educate them as to why that won't be the case.
Well, it's never going to happen.
It's never going to happen. Yeah. But what can we do to improve you? It's not about making you perfect as if you had never had kids, you were 20 and you'd never gained weight. It's about what are your checklist of things that bother you? Can I address each of those in turn? And then once I say, yes, we can address them, do you accept the limitations that I'm outlining? And once you've accepted that, are you willing to do these things that make that possible and safe? And that's really the equation, the journey you have to go through before you say, yes, I'm having surgery.
Now, obviously you're in demand as a plastic surgeon and you still work in the public sector.
Yeah.
Can you tell us why? And I know why, but I'm like,
yeah.
And I love how you do.
Yeah, yeah. I work in 2 public hospitals, the Alfred and St Vincent's.
Yeah.
There are multiple facets to that. One is that Firstly, the collegiality. It can get very lonely in private when you just have yourself or one or two people. Wednesday this week, I went to the Alfred. We had a patient who went to intensive care, had some difficulty, survived and was fine, but there was a very rigorous audit of what exactly had happened, as in a review from inside the surgery right through to the time they came out of ICU and discharged home.
Yeah.
So that audit process isn't really enforced in private, and it's very, very important. Secondly, the backup of a team, so you can bounce ideas off each other. We do a ward round, we see all the patients, we have a coffee, and you're actually bouncing ideas off each other, giving advice to juniors, getting advice if you need it for a difficult case someone might have seen, asking questions. That collegiality, the problem-solving aspect, it's really enriching for both the questioner and the answerer. There's juniors we teach. We teach the next generation how to operate, how to judge, how to think, how to be a doctor. That's mainly in the public sector. And then I think there's also the resources where you've got, say, the Alfred, you've got an ICU, you've got 24/7 junior doctors, all tiers of doctors, all specialties. And so if there's a complex patient, a dangerous patient, or a patient that's in danger, having that whole team there around it, having the multidisciplinary team. So I took another patient who had a terrible nasal cancer. I took him to the
nasal cancer. I've never heard of that.
He had a skin cancer on the nose, which is threatening much of the nose. And I took him to the team. In one go, we've talked about him. We've seen an oncologist, a radiation oncologist, a nuclear medicine doctor, plastic surgeons, dermatologists, nursing staff.
So you've got the whole team there.
So the multidisciplinary meeting gives such a good standard of care as well. So those are the reasons. And also the caseload that comes in, you don't see in private. The multi-trauma, the big head and neck cases, challenging.
Can we talk about them? Some samples of cases you've worked on?
Trauma hospitals like the Alfred Royal Melbourne, we have regularly motor vehicle accidents, workplace injuries. There'll be limb amputations, crush injuries, rollovers. So you've got limb amputations, threatening amputations where you have to revascularize them, parts off where you have to replant them, replant fingers, replant hands. You've got major trauma to the body wall. You've got orthopedic trauma in the legs where, yes, they can fix the bone and put metalware, but if it's exposed, it gets infected, they lose the leg. We cover it for them. Head injuries, there's bits of debris and metalware that's injured the vital cavities of the body, being the head, the chest, the abdomen. So, and there's no injury that comes in is ever identical. There's always nuances, always challenges. And it's that problem solving from your kit bag of all the stuff it took 18 years to train when I was from medical school through to including PhD and advanced training. That 18 years is just like, what do you have in your kit bag to fix that problem? And it comes in, it's like on the spot, right? It comes in, you're on call, bang, here it is, what are you going to do? So that's addictive. It's sort of like
you like the kind of the pressure and the kind of.
It's like a surprise chef if you ever watched that show in the 90s, right? Yeah. It's like, what are you going to do with this?
His arm's been chopped off. Let's reattach it.
And it might be, I remember one day we had a patient who came in. There was a 65% burn in one cubicle. There was an arm amputation in another cubicle, and there was an open facial injury with an open head in the next cubicle.
You amputate arms as well.
Yeah, well, we decided to put that arm in the bin. We didn't replant it because the trauma was too significant. But we do amputations and we do replants but that decision of, so it's again really important to take the vascular, the plastics, the orthopedics, the trauma surgeons conference and say, this limb is salvageable, this limb isn't salvageable. If it is salvageable, you start that process day dot. If it isn't salvageable, you amputate it and get on with rehabilitating them so that we can then replant metal stems into the body and put a prosthesis. And the prosthesis are amazing these days. So we know that for a below knee amputation, the patient's recovery and walking is actually superior in some cases to a limb where you spend a year reconstructing it and putting it back together.
Have there been situations where a doctor that has been on duty has missed something, you've come in and said, no, we've got to do this differently. This is not working. Ever had a situation like that? You see it in TV shows.
Yeah. I mean, look, I think the thing that people...
They're not throwing anyone under the bus here.
No, not at all. I think when people see a case, right, and it's presented in its totality, like we have reports from from either the coroner's report or the Medical Defence Association. When they're put in that sort of in a paragraph, it looks often really stupid, but no one went out there intending to make a stupid decision, right? Yes. sometimes facts evolve. Sometimes you're working on facts that you have been presented, after the fact. Sometimes it's too late to change the original decision. So I think I'm always wary of saying that, you come in as the great hero that saves the day, because under the same circumstances, with the same information, you might have made the same decision, even though it looks like you wouldn't have, right?
Yeah.
I remember there was a patient I had who still haunts me today, a patient who had been burnt by someone in the burns. I was a burns surgeon on call, and we had to make a decision to palliate.
You were on call?
I was on call, and we had to make a decision to palliate the patient. It was unsurvivable.
Oh, sorry, what's palliate?
To let them pass.
Yeah.
You just let them succumb to their injuries because they're not salvageable. And so that decision, right, you make the decision on the time with the information available. If some other piece of information becomes available retrospectively, you regret it, you can't go back, right? The decision's made. So I think I'm always hesitant about saying, we came in and we made this decision. I think that's part of being a team, part of having a team of emergency physicians, trauma surgeons, plastic surgeons. Everyone together makes a collective decision, and we test each other. And, if there's someone who comes in, there's a person who's on call and they go, geez, I really need a sense check on this decision I'm about to make. We're always available 24/7. A colleague picks up the phone, rings and says, listen, this is what I got. What do you think?
Yeah.
24/7. And that's critical because sometimes there are so many overwhelming factors. Like that day I mentioned, there were 3 or 4 patients. There's so, the intensity when you're in there in the moment is extreme. And sometimes you miss something, or you make a shortcut in your head, or you make a decision that's maybe not as pragmatic as you would have done if there was one case at a time and you had time to think.
Yeah.
So I think that's the human error bit. No one's a Superman or Supergirl, and you just have to always remember that things don't always go perfectly. You have to assume your own fallibility, right? Assume that you are, no matter how much conviction you have on that decision, there's a possibility that you're missing something. There's an influence. There's a bias. You're not making the right decision, and be humble about that, and always fact check yourself and put yourself. I always make the call, making a decision. If I'm going to operate, what would it be like if this doesn't go the right way? And I'm calling the family and telling them about it.
I couldn't fathom that.
Right. So it's a paranoid way to think, but it's a necessary way to think.
Yeah.
Don't assume everything will go well. In fact, quite the opposite. Assume everything goes wrong. Was it justifiable? Was it defensible? When you're talking face to face with their loved ones, was it the right decision?
Yeah.
And that's a critical part of it.
Yeah, I can only imagine operating on someone and they do pass, you've got to tell the family. How do you tell the family this? I'm sure that's happened before.
Yeah, look, thankfully not in the elective settings, but certainly there are patients who we are trying to salvage from trauma in particular, from burns and those sort of things. And there are patients who need something done where there's a high chance of a complication. I had a patient early this year where they were getting a benign tumour in the brain that was growing, and it was crushing their movement centres of their body. So they were becoming increasingly paralysed, having falls. They were on blood thinners. So this was a life-threatening situation, slowly evolving. It wasn't going to kill them that day, but maybe tomorrow. Maybe, and the speech was going. And so it was deemed that this was a necessary operation to do. But the risks in this patient were extreme. And so we had these family meetings so that they understood. And in the end, they have to understand it's not my life. It's them signing their consent that has the risks of, yes, things hopefully go right because we've predicted the risks and tried to mitigate. But there's also the whole side of it where, what if they go wrong? What's your plan B, C, D, E? What's your lifeboat to get out of trouble if an unforeseen thing evolves? Now, if you have none of them and you're just rolling the dice, sometimes you don't operate, right? Maybe it's the best thing not to operate. Even if you think you should operate, the patient and the family need to ultimately make the decision, because it's not just because you can, you should, right? It's what is the bespoke solution for each and every patient that gets them as close to the outcome that they're after in a realistic and safe way.
Yeah.
And that's the whole equation.
You mentioned earlier that Microsurgery was born in Melbourne.
Yes.
What are your thoughts on the cosmetic surgery industry in Australia? Do you think it's leading the world? Because a lot of people believe that the best surgery is done in, say, the US.
Yeah.
What are your thoughts on, say, Melbourne or Australia in general?
Well, Melbourne is, and I'm biased, Melbourne is really still a mecca
You're not biased.
It's a mecca of plastic surgery globally. Now, we think of
Is it really?
Absolutely, yeah. So I'll give you an example.
I never would have picked that.
So I've mentioned two of the doyens, Professor Ian Taylor,
yep.
the late Bernard O'Brien, who gave his name to the institute I'm director of. They changed the world, and they've brought generations of trainees here. So a lot of the heads of the unit, we've got a meeting in March, a lot of the heads of the units in big global centres trained here, right? That's number one. Number two, it's not just aesthetics. So there are a couple of doyens of aesthetic surgery. Probably the most widely known in facelift circles is a guy called Brian Mendelsohn, who's recently retired. He created a course called the MAFAC course, which is the Melbourne facial anatomy for facelifts. And he's the doyen globally. Every big facelift surgeon.
He's the godfather of it.
He's a godfather. Every big facelift surgeon globally who you read about in the media, New York, LA, London, wherever, they've all done his course, right? So, and he's a humble guy. He's really, I mean, he's well honoured in the industry. He was at the Mayo Clinic recently getting these huge awards. But this course is really the gold standard of facial anatomy. And he's changed facial anatomy and changed facelifts. His concept was, I got him to do a talk at one of our annual conferences. I called it the space age because he said there's spaces in the face. He just tipped it all on its head by conceptualizing there's spaces. You have to release the ligaments around it. Then you can move the spaces in the face to lift and transform the aging process and rejuvenate. But conceptually, he's actually completely changed aesthetic surgery. So it's not just reconstructive and microsurgery. There's something in the water in Melbourne. I think it's the cultural element, and it's what I call it is contagious curiosity. So, for example, Ian Taylor affected me, but I've had mentors like Brian Mendelsohn, Keith Mutimer, Tony Holmes, other people not just in reconstructive, and that curiosity and desire to always innovate and do better, which is inherent to true plastic surgery, that is infectious. And once you get a taste of it and you see how it can improve patient outcomes, it's exciting and it's infectious. You don't sleep, you think about it, and then you translate that into your research, going beyond surgery into the molecular side, doing the same things, maybe different things for the patients, but doing them with even more. It's like microsurgery was under a microscope. Now we're going subcellular microsurgery to do molecular biologies and things like we're doing at both the O'Brien and at Gertrude Biomedical. It's just so exciting.
Interesting. What are your thoughts on non-surgical treatments such as threading in the face?
Yeah.
Are you for or against, say, threading?
Yeah. Look, I think the concept that applies is that, if all you have is a hammer, the whole world looks like a nail, right? So if you have one tool in your kit bag, you'll always use it, no matter what the person is who comes in. So really you have to have the whole armamentarium. The other aspect to consider is that with something like threading, or fillers for that matter.
Can you mention what threading is?
Yeah, so threading is basically a way of doing a facelift where it's not in a – pardon me.
I need a water break.
A water break, yeah. Too much talking. So threading is basically where you do
more water?
Yeah, I'm good.
Okay.
Threading is basically a concept of where you do it without surgery. You put a little thread through the skin and you pull up, affecting the line of the skin drape, I guess.
So it gives you a jawline to a degree.
But it's not actually doing what a facelift does, which is going in those planes and those spaces that I mentioned and releasing and then moving the whole thing as a unit. So it's kind of a temporary sort of fix. The real problem from my point of view, and I did a facelift earlier this year where there was threading had been done in the past, it makes the subsequent surgery, if they have surgery, riskier and more difficult to do and to get a good result. So the issue with some of these non-surgical things is you have to ask, what's the impact down the track? So if there's a young patient, they have threading and say, look, I'm not ready for facelift. They do it, and then 10 years later, 5 years later, they need a facelift. The facelift suddenly becomes riskier, becomes harder to do, risking the nerves that go through into the muscles of the face called the facial nerves.
Why is that?
Well, the threads literally go in the same plane and the nerves cross them. You're doing it blind. You're passing the thread through blind. So you can't see if it's going through a nerve, around a nerve, wrapping around a nerve. So when you come in later to do the facial surgery, the facelift surgery, the whole key to that is finding those nerves, protecting them, then doing the lift. But if you've got scar tissue around or you've accidentally caught the nerve when they did the threading, then it's much harder. And sometimes you have to cut through that scar, risking more damage to the nerve, which means a facial droop.
Have you ever seen the facial droop?
Yeah, definitely.
And can it be resolved?
So the facial droop, the facial nerve comes out in front of the ear and it spreads like fingers of the hand up to all the different areas. Now, you can have trauma to that from an accident. You can have a cancer surgery that takes out some branches of the nerve.
Yeah.
Or you can have aesthetic surgery where one of those nerves is inadvertently damaged. Thankfully, the latter doesn't happen that much, but it's the thing we lose sleep over doing facelifts because those nerves are so delicate. They go in a very discrete anatomical plane, and any revisional surgery, whether it's revising after a facelift or a thread lift or just even fillers, the scarring and the changes from taking it from like untouched sort of virginal tissue to being traumatized, damaged tissue, that increases risk of nerve injury, but also means it's harder to get that nice pull and traction on the skin to create the aesthetic result people are after. So sometimes it actually sabotages you long-term for a short-term gain, which might be seen as cheaper, quicker, easier. But when you actually, the thing that you probably want down the track, if you're getting it at that age, that becomes harder and riskier.
So basically you would recommend against threading, and it doesn't give long-term effects anyway. It only lasts, 12 months?
Some are less. Some people come at 6 months. Yeah, but it's a short-term gain, but the problem is, as I say to patients, when you do something in surgery, it's done. You can't press undo, delete, and go back to how you were. There's never any state where you are as good as you were before you had the surgery. So when you have surgery, you really have to make sure it's what you want and why you're doing it. It may not be aesthetic. It may be, a lot of the lipedema ladies, they're actually trying to get their legs lighter so they can do their 20,000 steps and go to Italy. They've always wanted this holiday, work, run with the kids or grandkids, look better in boots, wear horse riding boots, whatever their aim is. You have to make sure that once they're doing it, they are doing it for the right reasons and they're sure that they want to do it because you can't undo that.
What are your thoughts on dermal filler, which is very, very popular?
Filler?
Yeah, filler.
Yeah. Look, I think it, like anything, it has its place. I think one of the big papers, interestingly, you mentioned is Melbourne, in the aesthetic space. Ian Taylor, the same mentor I described, and Mark Ashton, another local doyen of breast surgery here in Melbourne, they published a paper which was the globally the winner of the global plastic surgery publications a couple of years ago, which was that when you inject into the arteries of the face, you can actually get an embolus, which is a piece of the filler traveling up inside the artery, blocking blood supply to a bit of skin and losing a part of the skin of the face. And in the worst case scenario, traveling up into the eye, causing blindness. So a risk of facial fillers is blindness and skin loss. Doesn't happen often. I've never seen it, but that is a risk. So the more adventurous you become with fillers, the more volume you put in. It's just probability. The chances of those complications goes up. Where fillers, I think, are really good, particularly around the lips and the oral area, just to discreetly fill up the superficial tissues. I think they're really good at that. Certainly patients who lose weight in the face, patients who have medical conditions. When there was a lot of, in the 90s in particular, early 2000s, there was a lot of the antiretroviral medicines came in for HIV/AIDS. And so one of the side effects of that is loss of central fat. So you were having a huge hollowing out of the cheeks, loss of trunk fat and muscle. And so that meant a wasting. A lot of high volume fillers were being put in to make that telltale sign of having the HIV/AIDS medications that was stigmatized at the time, not so much now, thankfully, but that was used to be able to have those people interact in society normally. So there are definitely reconstructive things, scar tissues, a traumatic divot if they've had a trauma to the face. Yep. You can mask these things with judicious, safe fillers. But again, the bulk use of them carries risk.
But doesn't too much filler, because I've seen a photo of a woman that had too much filler.
Yes.
And the filler, because of gravity,
migrates
down.
Yeah.
And it kind of sunk it to the bottom of her face.
Absolutely.
Can that happen?
Yeah, I've seen it. And I've got patients who sadly have had it in excess volumes. It's like anything, right? So, for example,
just sinks.
Yeah. And it's supposed to go away, but I think some of the scarring and the fluid that accumulates around it does cause weight, stretches the skin, drops, and that's a really hard thing to get rid of. A lot of the sort of cosmetic tourist industry, which you'd be familiar with, they're never seeing the patient again. They just bang anything in. It may be substandard. A lot of patients come back with silicone injected into the nose overseas, silicone which is not even medical grade, and it erodes through.
Geez, that can't be good for you.
No,
literally.
No, it's not good.
Eventually it's going to do damage to your body.
Yeah, and that's the thing. I guess that's the thing with medical tourism is that when you travel abroad, you come back and again, you're assuming, by definition, everything will go perfectly. Because if it doesn't, then your doctor's not there to correct things. And really when something goes wrong, anyone who tells you there's no complications in their practice is lying to you, right? Everyone, if you do enough surgery, by virtue of the fact that there's genetic diversity, there's different medical background, they will have some complications, something goes wrong. But it's not a measure of that. It's the fact that are you willing to stay the course with the patient, offer them care, understanding, support, and fix the problem? That's the test and by definition, if you're traveling overseas, you forego that ability to have that. And I think also the fact of travel itself does change things, because if you imagine you've had surgery, it's like the water bottle you take on the plane that's already opened or whatever. You see the compression at altitude changing the pressure within the water bottle. Same happens in our blood vessels. So if you've had surgery, you jump on a long-haul flight, what happens is the vessels in your body, relatively speaking, your blood pressure might be the same, but it's as if your blood pressure went up. So you'll bleed more, you'll get more seromas.
That's why they say you can't fly after surgery.
Yeah, that's right. And it's also, apart from being painful, the fluid in the lymph, the serum, and the blood comes out. So when people say to you, you need to wait 3 months after your surgery to travel long haul, there's a reason. People who shortcut that and go 6 weeks and they go, look, there's a seroma, I bled. Well, that's why we said not to do it. Yeah. So you have to take responsibility for your own actions as a patient as well. I think that's very important, but also you have to be informed about don't travel, don't do this, don't go on a junket, don't go and exercise excessively. And that's why it's not just because we're being mean, it's because we're trying to protect you from potential complications.
And people that have had too much filler and the filler does droop, can it be treated and how can it be treated?
Very, very difficult. So there's theoretically there's a thing.
Droop is my scientific term. Droop.
Yeah, droop's a good term. Droop's a good term. So the droopiness or the dropping, we call it ptosis, is the medical term for something dropping, be it breasts or any other body part. That is, if you try and dissolve with these substances that are able to theoretically dissolve the filler, remember it's dissolving things that also occur in the skin. So I've had some patients where they've had excessive filler put in, they've gone after it with some dissolving agents, and then the skin is like rubber, like elastic.
Shit.
So the problem then becomes they come back and go, can you do a facelift or can you get rid of that loose skin wherever it is in the body part, on the body?
Yeah.
And you can't because the tissue is like chewing gum. But to come back to Radek's company without giving him a plug, the MyDNA or any other DNA company for that matter.
Give Radek a plug.
Yeah, I mean, I use MyDNA for all of my patients now that will be able to do it. Yeah. So we came back with this patient who's had this massive weight loss and we're wondering why everything we do, her skin stretches after 6 months again. And we came back today and the panel, she had 7 collagen problems.
Collagen related.
7, not 1, 7. And that suddenly we breathed a sigh of relief and we said, well, this is why this is happening. And so if we'd known that, would we have chosen to do a different surgery? Would we limit what we did? Probably, right? So that's where it's going, is having bespoke, not just for the patient, those things I mentioned, can they, is their lifestyle, is their family support, is their ability to tolerate scars, is that all good? But what about now their genetics?
Yeah.
And that's where that tees into the lab work and the research work. And that's why this is the dawning of a more educated era where you can tell patients, as you know, what nutrition they should be having, but also what surgery they should or shouldn't be having. Should they be having filler? Will they retain it? Will their Botox work? All those things will be a readout on a genetic printout at some day.
So are you suggesting that people that want aesthetic surgery, you would recommend they do a DNA test or consider it?
I think you don't do a blanket test on everyone, but the patients I'm talking about are ones who've either lost weight, they've got stretch marks. So there's a reason to suspect first,
gotcha.
And then you can nail down the actual cause with that DNA test.
Yeah, gotcha.
Yeah.
Now, can we talk about your, I say passion project?
Yep.
Your cancer research with stem cells.
Yes.
Can you elaborate on that?
Yeah, so in my PhD, we collaborated with a couple of guys from Queensland and we found that they had this mouse that was swollen full of fluid. What we did, we created a little plugin for an ImageJ software that was able to quantify what these vessels did, what the mouse was doing, and we found that the vessels were deranged with this genetic mutation. So the lymphatics and the blood vessels hadn't formed in this mouse. The blood vessels meant there was poor blood supply. The lymphatics meant it retained fluid. So we switched it and we said, well, what if we know that cancer uses those two vehicles to both grow and to spread. What if we switch it up and we try and block that process where you don't want it to happen? Obviously, in the embryo, you want them to happen. But if you don't want it to happen in cancer, i.e. you don't want the cancer to grow and spread, what if we switch it up and make a blocker for that? And that's what we did over the last 5 years. Long story short, we took a molecule and we started with a starting molecule, tweaked it around 3,000 times to find the characteristics that can block it. And so blocking that SOX18, it's called, that it's a transcription factor. And what a transcription factor is, to digress, is if you think of the DNA, it's like the copy, the Bible of the whole body's blueprints of every single thing and process that happens. Now, if you want to make something happen, you take a page of that and you photostat or photocopy that page and give it to the factory floor, and they will manufacture it in a separate thing called a ribosome. And the manufacturer is protein, and proteins make things happen in the body. Now, what if you could jam the photocopier that photocopies that page and it never got to the shop? And that's never been done. 25% of cancers in the genome are somehow related to that photocopier, but we don't know how to jam it. So what we've done is through this iterative process of 3,000 steps, we've created a drug that we've found is blocking the SOX18 photocopier. What that's showing us in our mouse models is that it's having a really good effect on the tumor growth and spread. And so we hope to be able to take that into clinical trial in the next 18 to 24 months.
And what type of cancers are you potentially going to treat?
So the one we've started with, we wanted to start not with the ones which have 90% survival rate. We want to start with the ones that have a death sentence. So we knew from the biology that a blood vessel cancer called angiosarcoma, which basically is so incredibly brutal when you see the patients have it. It's just the cruelest thing.
Is that a brain cancer?
It can occur in the head and neck. It can occur in the breast, especially after radiation. So people think they've got through their breast cancer with radiation. A couple of years later, suddenly there's this growth. And so this angiosarcoma is a very aggressive cancer. It's made of blood vessels and it grows and engulfs the area the body's growing in and suddenly spreads. And so any colleagues who've looked after these will tell you it's a brutal disease. We decided to go for this because it was an unmet need. The survival was like 20% 5-year survival. Once you have metastases, you live no more than 3 months. It was a brutal cancer. We thought we'll start with that because the biology fits what we're doing, but also because it's a rare cancer. There's certain designations and things that the FDA in the US, the Food and Drug Administration, they give you a concession, they give you extra patent life, they give you expedited review so you can get it into patients more quickly. So we went with that, but we hope to expand that out into other types of cancers as well. Other difficult to treat cancers. We're after things like ovarian, which has got resistance to chemotherapy, traditional chemotherapy, gastric and esophageal, brain, lung, those ones that are the ones that are really still 40 years after my uncle died of his brain tumor, still a death sentence. Why? We haven't unlocked the secrets yet.
Yeah, my question is why? Because billions and billions of dollars goes into cancer research, but why can't we solve this situation? Why can't we find a cure?
Yeah. Well, first of all, cancer is multiple diseases. In fact, every different type of cancer is itself multiple diseases. So there's many, many types of cancer. Sometimes the unique gene signature is unique to that patient. That's one reason. The second reason is that there's big money in reiterating and recycling without risk.
Yeah. Or keeping them well enough to stay on the medication.
That's right. I mean, you're keeping people alive a bit longer. And so you might be going from, spending billions of dollars going from, say, 5 years to 6 years or 10 years to 11 years.
Yeah.
But there are some cancers because they're not in a big enough market, they're not sexy enough, they haven't had a celebrity who's had it. For whatever reason, there's not money going towards that research, or it's a pioneering area and higher risk, therefore. And if you're a pharma company, you make incredible money.
Let me ask you a question. I gave you $10 billion and 300 of the world's best scientists.
Yep.
Do you believe you could find a cure for cancer within 5 years with $10 billion and the world's best scientists?
I think that you could find cures for multiple different subtypes of cancers that together, if you look at overall survival from cancer, would make a contribution to that. Yes.
Yes, I think yes, you could. It's just
absolutely.
We don't make any progress in this area at this stage.
The system's very set, and the system works if you're a pharma company.
Yeah.
But if you're a patient who has a cancer that is maybe the pharma company might know that you are able to be treated with that, but it hasn't been fully researched or marketed, and you don't have an oncologist who knows their way around the back streets to get a compassionate application, you might just be a victim of bad timing, right? And that's the truth of it, because certain drugs are approved for certain diseases. Unfortunately, they might work for the next disease, but you would never know because the research hasn't been done. The time's limited, the money's limited, the appetite to look in that direction's limited. And so the strategy of the pharma companies is to do what they do and make profits, and they do that well.
Yeah.
But I think in Australia, we have this great opportunity in biotech in particular to make it one of our leading pillars of the economy. And because it's something, we have the resources, we have the brain power, we have the institutions, we have the great hospitals and world-leading doctors. Yeah. We have the IP that our scientists generate, but it sits there dormant. We're very bad at commercializing it.
We are. Yeah, we are. Or we don't invest money in the right areas.
The risk appetite's not there.
Yes.
Right? So the risk appetite is,
in the US, completely different.
It's a different story. They're looking for, okay, tell me the 5 times you failed so I know you've had the pitfalls and you can fix this. In Australia, the mentality is, we're very safe. We invest in mining and banking and agriculture and property.
But not life.
But not in life, right? And why aren't we investing in stem cells and life? Because some of these diseases, right, like the SOX18, for example, some of the things downstream of it are involved in longevity. But it may never get to the light of day if you can't raise the funding to get it through the cancer trial and make it an approved drug in some sense. We're very good at all these things in Australia. We're very good at lots of fundraising and finance and all these things. But the silos exist independently. And sometimes guys as different as we are never get to connect and talk, right? Melbourne's great because Melbourne has enough of every specialty of person, right? It has a radic, it has a U, it has all these different people. And it's small enough that they can meet, but it's big enough that you have the diversity of skill sets. It just needs someone centrally to facilitate connecting those silos of excellence together, facilitating them to happen and providing funding for it. Because I think the intention's there, but it's just that last step of getting it over from great academic research, funding it through that valley of death stage where there's limited funding and limited expertise in Australia, having it stay onshore, not go to Silicon Valley or the US where there's a lot more money, and keeping it through to fruition where at least the phase 1's done in Australia. So we've created this pipeline of digging up the raw material, the IP from the university, putting in a value add, and then selling it for benefit to the country. And that's ultimately what we need to do.
Yeah, I think you're correct. I think the intention is definitely there to do a good thing or do the right thing. I just think we choose the wrong areas to invest, and I think we choose to keep people in jobs rather than find cures and treatments.
Yeah. Yes.
And I can't see that changing in the near future.
Yeah.
Can you?
I think it needs courage. I think it needs political courage to change things because, as you said, there's a risk element to it. I think a lot of what's done in the US, okay, we don't have the safety nets there that we have here, but we have the risk reward is far greater. For people who go out and be entrepreneurs, for people who roll the dice and say, I might lose it all, but hell, what a difference I make if I find a cure to cancer. Yeah. The culture is different. So I think the leadership in the country needs to embrace that risk appetite and rolling the dice on this. I mean, in fairness, this startup we have, I didn't need to do that, right? I didn't need to do it in terms of financially or whatever, but what I needed to do was a moral and ethical imperative that I couldn't walk past this because, okay, they told us there was a 5% chance of success when we started. But if I was walking past in 10 years a patient with that disease that I elected I was too cowardly to roll the dice on it or too timid to roll the dice on it, and I'm watching those patients die for the rest of my career, there's a 100% chance that I will look myself in the mirror and really despise what I see.
Yeah.
Right? That's 100% guaranteed.
Yeah.
At least this way, okay, things might fail, but I rolled the dice. I didn't just talk about it.
You gave it a crack. You tried.
And that's all you can do.
Yeah.
Right?
Because is that 5% now 10% or 15%?
Well, I mean, I think it's much higher than that because the drug itself is now created. It's ticked the boxes from what we want. Now it's more getting it from the mice that we've tested it into the larger animals, the rats, the pigs, and then the largest animal, the human. There are certain procedural elements to it. There's toxicity that could arise in a different species. There's various things now, but I would like to think there's sort of like a 65% chance now. Compared to
compared to 5% 3 years ago.
5%, and they told us we wouldn't get to where we are now.
There you go.
So that alone, forget about the money.
With no government funding.
Zero government funding. All friends and family, local doctors who see the diseases. Incredible. It's exciting, right? But even if, as I say to my wife, even if this now doesn't go to a human treatment, the contribution that has been made with the financial drivers that make progress happen so much more quickly than they can happen in, say, an academic setting, that has been a contribution that excites me and I'm proud of.
The Australian Cancer Council has probably raised billions.
Yeah.
I always question, where does this all go? Anyways, that's a topic for another discussion on a Sunday.
Yeah.
Ramin, you're a good man and you're a true artist, and thanks for coming on.
Thank you very much for having me, Nick.
Thanks, mate.
Cheers.